Welcome to The Gut Show. I'm your host, Erin Judge, registered dietitian and founder of Getelligate. I'm also your fellow IBS warrior. Our goal on this side of the internet is to empower those with IBS and digestive disorders to understand their gut better, to have a healthier relationship with their bodies, and to make confident choices to improve their digestive health. During this season, you can expect a conversation around a hot topic related to gut health, digestion, and IBS. As a disclaimer, I am a dietitian, but I am not your dietitian. So everything covered in this episode is meant to be educational and is purely information that you can take back to your healthcare team in order to make the best decisions for you. If you're new here and something just doesn't feel right in your gut, if your symptoms have led you to this podcast, I invite you to start by taking the quiz, What's Your Poop Personality? Your personality type will unveil what your symptoms may mean, what may be causing them, and what you can do about them. This is a free quiz and you can take it today at getelligate.com or find the direct link below in the show notes. While you're going to take the quiz, let's jump into today's episode. Now for a quick word from our sponsors with resources that might support you. Did you know that you can now order your own gut health test without waiting months for a doctor's appointment? Gemelli Biotech offers trusted, science-backed, at-home tests for conditions like SIBO, EMO, ISO, and post-infectious IBS. Their Smart breath test measures the three key gases, hydrogen, methane, and hydrogen sulfide, to detect different forms of microbial overgrowth. As for those with IBS symptoms, IBS-Smart is a simple blood test that can confirm post-infectious IBS with clinical accuracy. Validated by the leaders in gut health, these are tests that you can trust and tests that you can take comfortably from your home. So go to getgutanswers.com to find out which tests are right for you and use the code ErinJudge25, all one word, ErinJudge25, to save $25 on your order. Is a gluten-free diet just not cutting it, or maybe not even necessary when it comes to chronic symptoms like bloating, gas, and pain? Research actually shows that in those without celiac disease, it's actually the FODMAP, the carbohydrate, fructan, in wheat, not gluten, that causes symptoms most often. This means that you may not need a strict gluten-free diet to see symptom relief. And it means that if you are reacting to fructans, there may be more foods in your diet beyond wheat that are causing you symptoms. This includes foods like garlic and onion, and even some fruits and vegetables that can sneak their way into your diet and contribute to those chronic symptoms. You can choose to limit these foods and reduce your overall fructan intake in order to avoid symptoms. You also have the option to break the fructan down using FODZYME, an enzyme blend that targets fructan, lactose, and GOS FODMAPs, and that will help you break these FODMAPs down to then prevent the symptoms. Learn more about FODZYME in the show notes, and you can use the code THEGUTSHOW for 20% off your first order. And now let's get back to the show. We are going to talk about malabsorption, masked as, and overlapping with IBS, which is a lot of words, but ultimately we're talking about, if you're hitting the wall with IBS, what are some other things that could be going on? If you're dealing with food-related symptoms with IBS or without IBS, what are some of the potential reasons for it? And then announcing our speakers today. So both of our gastroenterologists are at the University of Michigan. They work with patients with functional disorders of the gut-brain interaction, including IBS and beyond. So upper GI conditions, gastroparesis, GERD. They're working in the space of SIBO. They're working with all the things that can also occur alongside IBS. They're also both researchers. So we have Dr. Alan Lee, Assistant Professor of Medicine in the Division of Gastroenterology and Hepatology at the University of Michigan. We also have Dr. Prashant Singh, who is also an Assistant Professor of Medicine at the University of Michigan in Ann Arbor. And one thing, I know Prashant a little bit more than I know Alan so far. Good to become friends as well. But the research that I know both of these incredible doctors have been a part of has been focused on the IBS space specifically, which is why I wanted to make sure that they were in the room, because the University of Michigan as a whole, but especially these two, have been working with low FODMAP diet research and actually looking at some of these kind of malabsorption issues and some of these, if we want to call them the causes of IBS or the drivers of IBS, like intestinal permeability, gut microbiome changes, all these different pieces that we're all hoping for more answers on. These are some of the doctors that are doing that research. So thank you both for being here. I'm excited to have you and for us to cover this topic together.
Great. Well, thank you so much, Aaron, and thanks for everyone for joining. So I'm going to start off by just discussing this concept of food intolerance versus food allergy. These are common questions that we'll get from patients when we see them in the clinic. And there's certain characteristics that can help us determine whether someone is more likely to have a food allergy versus food intolerance. So food allergies, these are immune-mediated reactions. So what do we mean by that? In people who have food allergies, their immune system are recognizing antigens within foods as being foreign, and that drives this immune-mediated reaction. And there's certain characteristics that are classic for food allergies. So one, they reliably occur after consumption of specific foods, and we'll talk about which foods oftentimes will drive these food allergies. The timing of this, typically this occurs within minutes of ingestion. And then some of the signs and symptoms are classic for food allergies. And this includes symptoms like cough and chest tightness, wheezing, hives, nausea and vomiting, diarrhea, angioedema, and then in patients who have severe food allergies can even include anaphylaxis. And then we also know that 90% of food allergies are attributed to only about 8 foods. And specifically, this includes milk and eggs, peanuts and tree nuts, fish and shellfish, and then wheat and soy. There are other food allergies that can cause GI symptoms, including conditions like eosinophilic GI diseases and then celiac disease. In the interest of time, we won't spend a huge amount of time on these conditions. Now, in contrast to food allergies, food intolerances are non-immune mediated reactions to food. So in food intolerances, the immune system is generally not driving these symptoms. And so similar to food allergies, there's certain characteristics that may suggest that people have food intolerances rather than true food allergies. So one, symptoms may be erratic. And so oftentimes when we see patients in clinic, they will tell me, I had a meal or a food today and it caused me symptoms. I'll have that exact same food or meal tomorrow or the next day, and I'm fine. And those are pretty typical presentations of patients who have food intolerances. The timing of food intolerances can occur up to hours after ingestion of food. And then lastly, they typically don't include some of the classic signs and symptoms of food allergies that we just talked about. Some food intolerances may be related to malabsorption, including carbohydrate malabsorption, bile acids, and fat. And we'll talk a little bit about this in the next few slides. And then food intolerances are common in irritable bowel syndrome. So we know from survey data that up to 80% of IBS patients report that food are common triggers for their IBS symptoms. So in terms of malabsorption, there are both primary and secondary forms. And so before we get into this, let's talk briefly about how carbohydrates are digested in the GI tract. And we'll focus on carbohydrate digestion, but some of the general principles can also apply to bile acids and fats as well. So when we eat a meal, carbohydrates and starches are broken down into smaller polysaccharides and then finally into monosaccharides. And then once they're in the simpler form of the monosaccharides, they can be absorbed in the small intestine by specific carbohydrate transporters. Now, primary forms of malabsorption occur because there's inherited deficiencies of these enzymes or transporters related to digestion. And these primary forms of malabsorption are typically more rare. Now, secondary forms of malabsorption arise from any condition that affects this digestive function and typically are much more common. And so examples of secondary forms of malabsorption can include things like celiac disease, which is an allergic reaction to gluten or the protein in wheat. And if celiac disease is left untreated, patients can develop damage to the lining of their small intestine, and this can ultimately lead to malabsorption. Small intestinal bacterial overgrowth, or SIBO, is another potential secondary cause of malabsorption. And then there's also conditions that can mimic malabsorption or food intolerance. So things like microscopic colitis or inflammatory bowel disease, these are chronic inflammatory conditions of the GI tract that can sometimes mimic malabsorption. And then we can talk about specific carbohydrate malabsorption syndromes. So sucrase isomaltase deficiency, this is a condition where people lack the enzyme sucrase and or isomaltase that breaks down sucrose, which is sugar, and then maltose, which is present in starches. This can be congenital or secondary, and we used to believe that the congenital form of sucrase isomaltase deficiency, or SID, was a rare disorder. However, more recently, there's evidence to suggest that even in patients who have a heterozygous mutation, so just a mutation in one copy of the gene, they may still experience symptoms from SID. And so this condition may be more prevalent than what we used to believe. In addition, SID seems to have higher prevalence in patients with IBS. So one report suggested that the prevalence of SID was about 7% in IBS patients. In addition, there's also potentially some clinical implications here as well. So, for example, Shantiaz Warren, who is one of the faculty at the University of Michigan, was involved in a study a few years ago where they looked at patients who had a mutation in this SI gene. And those patients who had mutations in this SI gene actually were 3 to 4-fold less likely to respond to a low FODMAP diet. And this is likely because sucrose is not typically restricted in this low FODMAP diet. How do we make the diagnosis of sucrase isomaltase deficiency? Historically, in the gold standard, this is typically through endoscopic small bowel biopsies, where we would test for sucrase and isomaltase activity. But as you can imagine, that is invasive and time consuming. And so there's less invasive ways that we can make this diagnosis. One of the more commonly used methods is through breath testing. And so in this test, patients will drink a solution of sugar water. Specifically for SID, they'll drink a solution of sucrose. And then we measure the concentration of hydrogen in breath. And because hydrogen is exclusively produced by bacterial fermentation, if we see rapid and large increases in hydrogen levels in breath, it suggests that carbohydrates are being malabsorbed in the small intestine, and then they're getting fermented by colonic bacteria. Treatment for SID largely is dietary modification, so reducing sucrose and starch in diet. And then we can also use enzyme replacement therapy with sucrade as an adjunctive measure.
Before we move on from this one, I'd
Yeah.
love for you to talk a little bit about, like, can this be secondary? I know, I think your team at the University of Michigan has brought that up. Dr. Che has brought that up sometimes. So can this be secondary and improve in a similar case to like the presence of celiac disease and that damage to the small bowel? Or has new research suggesting that it doesn't actually improve and it's not truly secondary at that point?
Yeah, I think with all of these carbohydrate malabsorptions, they can be secondary. And as we'll see with lactose and with some of these other carbohydrate malabsorptions, some of this malabsorption actually may be physiologic. So I'll talk about this a little bit in, specifically with lactose, but as we get older, our expression of these transporter and these digestive enzymes actually decreases with age. And SID is pretty similar. There may certainly be secondary reasons why people are getting this sucrase isomaltase deficiency. So lactose intolerance is another common cause of carbohydrate malabsorption. This lactose intolerance occurs because there's reduced or absent expression of the enzyme lactase that breaks down lactose. And as I briefly alluded before, lactase expression peaks shortly after birth, and then it slowly declines starting from childhood. And so as we become adults, most adults actually don't express lactase. Looking at prevalence of lactase activity worldwide. About a third of adults actually have some lactase activity. Prevalence is highest in people of Northern European ancestry, but that prevalence declines as we move south and east. Similar to SID, lactose intolerance seems to be much higher in IBS patients. And then the diagnosis and management are pretty similar to SID. So endoscopic biopsies can be used to measure lactase activity, but typically breath testing is a much more convenient and non-invasive method to make this diagnosis. And then management, again, largely revolves around dietary modification. We can use lactase supplementation as well. It's interesting to note, though, that even in adults who have lactase deficiency, a majority of people can still tolerate up to 12 grams of lactose, which is about a cup of milk, without causing symptoms. I am going to turn this over to Prashant now.
Thanks, Ellen, and hello, everyone. Thank you for joining us. I think Alan covered a lot of causes of the IBS mimickers, such as disaccharidase deficiencies, which including CSID and lactase deficiencies. But there are other causes which I will go over. And one of the main causes, especially for patients with IBS who have diarrhea, right? Not so much for patients with constipation, but mainly with those who have diarrhea, and maybe even with mixed subtype, that is those who swing between diarrhea and constipation. One of the causes of their symptoms could be malabsorption of bile acids. So, I think we're going to go over just a quick physiology of how bile acids actually get metabolized in the body. And as you can see on the figure in the right, it is the synthesis of the bile acid starts in the liver. So liver converts cholesterol to C4, which is a precursor of bile acid, and then eventually to bile acid. It's stored in the gallbladder. What happens is when you eat food, the gut hormones send the signal to gallbladder, hey, it's time to squeeze and get started. So the gallbladder squeezes, releases the bile acid. Bile acid will go into the small intestine, mix with all the food you have just eaten and broken into smaller pieces with stomach, and there it helps with absorption of fat and fat soluble vitamins, and then what happens is then as it reaches the ileum, which is the end of the small intestine, about almost entirety of the bile acid gets reabsorbed. So 95% of it gets reabsorbed. And this is body's way of not doing extra work when it doesn't have to, right? So it's body's way of maintaining this homeostasis. The bile acid gets reabsorbed, it gets recirculated again, and then the 5% will get excreted into the colon and will come out, where it will get metabolized from primary bile acids to secondary bile acids with bacteria and gets excreted in the stool. But enough about physiology, right? Like and there is a reason we are talking about this, which we'll get to in a second. And what happens in some people is this loop, right? This negative feedback loop, where when the ileum is seeing the bile acids, it's reabsorbing them, and it's preventing the chain of starting the synthesis of the bile acid again. This negative feedback loop is very important in the body, and sometimes this loop gets broken for whatever reason, right? And that causes bile acid diarrhea. And as you can see, right, we'll highlight where the loop can get broken. If you don't have a gallbladder, right? So one of the main reasons is when you don't have the gallbladder, there is nothing to store the bile acid, and the bile acid kind of just leaks into the small intestine. So there is no control of how much bile acid is being leaked into the small intestine, so as to speak. And that can, if you have a lot of bile acid in the small intestine, of course, there will be a lot more into the colon. And actually, bile acids are like detergents. So they can irritate the colon lining a lot, and colon doesn't like bile acid. So whenever colon sees bile acid, the first thing it's going to do is secrete a lot of water to wash it away, because it's like, oh, I don't like this, I just need to get rid of it, and that's what causes diarrhea. So I would think of bile acid as detergent or irritant to the colon lining. So anything that causes more bile acid in the colon is going to give you diarrhea. And as I just said, if you don't have gallbladder, you don't have that much control of how much bile acid is leaking from the liver into the small intestine. So you can end up with more bile acid and therefore more diarrhea. The other, as for whatever reason, some people who have ileal disease, like Crohn's disease of the ileum, or have had ileal resection for whatever reason, right? Like they could have ileal resection related to the Crohn's, related to a stricture, related to complication from other surgery, from radiation, all of these things, wherever the ileal disease is, or the last part of the small intestine is not there, you can see there is nothing to control the negative feedback, right? So this feedback, which is the ileum is giving to the liver, is lost again, and then there is more bile acid again, and then more diarrhea again. And in a group, equally important is like a group of patients, which is what we call as idiopathic bile acid. So we know that there are some risk factors like not having gallbladder, having ileal disease, not having ileum, right? But then there is a group of people who have idiopathic bile acid diarrhea, meaning we don't know why, but this loop seems broken for some reason. They end up with more primary bile acid in their colon and therefore in their stool. And what happens is that, as I just said, if you're going to have more bile acid, it's going to irritate the colon and you end up with more diarrhea. And that's called primary bile acid diarrhea. And an important finding to remember is up to 25% of patients with these diarrhea-like symptoms, both IBS with diarrhea and functional diarrhea, would have bile acid as one of the main causes. So if you screen 100 patients with IBS with diarrhea, about 25 of them will test positive for bile acid diarrhea, which is a huge number if you think about it, right? That's like 1/4 of our patients, right? And when do I suspect I have bile acid diarrhea, right? That's kind of the thing, because in the end, it's just diarrhea and pain, which is like, how do you differentiate it's bile acid versus not? So clinically, unfortunately, there is no one sign that can say, hey, you have bile acid diarrhea versus you don't. There are some tricks we use in clinical practice to kind of hint towards it. One of the tricks is obviously if you have a risk factor, if you don't have had gallbladder, or if your symptoms started immediately after gallbladder or got worsened after gallbladder removal, right? If you had ileal disease for whatever reason, as I just said, so if you have a risk factor, obviously that's concerning, right? The second thing is that if the symptoms are generally postprandial, so postprandial diarrhea, right? You eat and you have to rush to the bathroom. That's a very classic sign of bile acid diarrhea. It's because that, you eat, the food is signaled by the hormones, the bile acid is secreted, and there is no control of how much it is, postprandial is after meal, and how much bile acid is being secreted. There is a ton rushing towards your colon, and that gives you diarrhea, right? So that kind of helps. And third is like, if you're eating a fatty meal, anything which makes bile work harder. So fatty meal, greasy meal is all that can also kind of hinge towards, right, that you might have bile acid diarrhea. So how do you even diagnose, right? Let's say you suspect that you have bile acid diarrhea, your provider suspects. The gold standard, unfortunately, is this test called CCAT test, where you ingest like radio labeled bile acid, and we scan you with a gamma scanner for after 5 to 7 days to see how much of it is retained and how much of it is passed out from your body, and we can talk about cutoffs, but there's no reason to, it is not available in US. And that's kind of one of the main limitation. It is available in other parts of the world. So generally 10 to 15% is the cutoff. Anything less than 15% is suggestive of bile acid diarrhea. Anything less than 10% is almost confirmatory of bile acid diarrhea in this patient population. And 5% or less is severe bile acid diarrhea, right? Unfortunately, as I just said, that test is not available to us in the United States, but is available to some of our other audience. I just heard people are logging from all over the world. So maybe you guys can utilize those tests if you are suspected of this disease, but we can't. So in the United States, there are a couple of laboratories which are commercial labs, but they can test the amount of bile acid in the stool. And of course, if you are beyond a certain cutoff, then it might make sense that you have bile acid diarrhea, right? But remember, those tests are like 48-hour stool collection, and who loves to collect their stool for 48 hours, right? So there are now emerging evidence that we can maybe look towards some blood tests like the C4, which I just talked about, which is a precursor of bile acid, as a marker for bile acid diarrhea. And the idea is that if your C4 levels in the blood is elevated, it tells you that you are making more bile acid than normal. So of course, your colon is going to see more bile acid than normal. And that correlates with stool weight, actually. But again, that test is not very sensitive, unfortunately. It is specific, but not very sensitive. So if it's positive, then you can at least say, yeah, you have bile acid diarrhea. But if it's negative, maybe it's because the test is not great to begin with. And remember, I think, so one of the tricks we use generally in our practice, and Alan would agree with me, is that we end up just treating our patients with a bile acid binder and see if the patient gets better. It's not perfect because of obvious reasons that, how do you know you are even getting enough bile acid binder? Like, are you taking enough to bind all the bile acids? But it's the best we have for most circumstances, unfortunately. So I'm hoping in near future, the tests, the blood tests or the blood test with a combination of stool tests become more available to us, to everybody. Right now it's available. The blood test is available with 2 commercial labs and stool test only with 1 in United States. So that's the kind of main problem. And as I said, treatment is bile acid binder like cholestyramine, qualsalvelam, cholestyramine, which is generally can be titrated to effect in most patients. And they are pretty effective for the most part.
To clarify some of the warning signs, some good questions coming in on that. When you talk about timing, so diarrhea quickly after a meal, is that immediately, like while you're eating, as soon as you finish the meal? Are you talking about 1 to 2 hours? Like how quickly?
Yeah, meaning there is no, as I always say, meaning we like to box human body into these like concrete forms, right? But that's not how body works, unfortunately. There's a lot of leeway. Most of my patients would say it is, sometimes it's during, depending on the severity, and sometimes it is, but mostly it's afterwards. It's within minutes. Like I finished a meal and it's like I have to rush within 30 minutes. A classic sign is like I was eating out and I had to leave my table and go to the bathroom, right? That's generally kind of the history when it's a typical history which you get. But it can happen up to 30 minutes to 120 minutes. Anything during that time frame, I would still take it as meal related.
Perfect. And fat, this was a great question because I know fat is often talked about with bile acid diarrhea, but someone said, is fat alone a trigger and that symptoms happen quickly? Could it be just that symptoms happen quickly, even in the presence of a lower fat meal? Like, does the fat content matter in these cases?
That's a great question. So I think, yes, they both can happen in isolation. Generally, patients will say that I have diarrhea after I eat. It's often, after, it doesn't matter what I'm eating, it can happen, but it's certainly much worse or much quicker when I eat a fatty meal. So I think fat is an extra trigger on top of just having relationship to meals, but it doesn't have to happen that you have to have both of those things. Right. Because remember, like some of it is anticipatory, some of it is as you're eating, the hormones are like, oh, it is coming. Like you're going to have some, like, your body kind of anticipates that you're going to have to digest this. So the bile has to come. So it doesn't have to be fat, but certainly not easy to digest with fat. So coming to EPI or exocrine pancreatic insufficiency, I'm sure people who are in the States have heard an ad about it while they're driving somewhere. But for people who are outside the States, the exocrine pancreatic insufficiency is a concept where pancreas doesn't, backtracking, the pancreas is the main organ which is kind of digesting everything you're eating, right? That's that's a lot of your work of digestion is to come from the enzymes which pancreas makes. So pancreas kind of has a tube which connects the pancreas to the small intestine. You eat, the pancreas secretes the enzymes and into the lumen, and then the digestion begins, or absorption begins. So if you don't have the ability from the pancreas to make these enzymes, you're going to not be able to break down your nutrients in the food or not able to absorb them. And that can obviously give rise to diarrhea and pain. So again, just like bile acid diarrhea, the EPI generally occurs in patients who have pain and diarrhea, right? Meaning IBS with diarrhea subtype. I rarely suspect it in patients who have constipation predominant IBS. That's not generally the group which I will go after once I'm thinking of for EPI, but mainly with diarrhea. Risk factors for it, obviously, patients who have a history of pancreatic disease. If you have had pancreatitis in the past, sometimes patients are like, I've had multiple episodes of pancreatitis, and then you obviously suspect this. Sometimes, unfortunately, patients can't give that history, right? Because again, it can be misdiagnosed, undiagnosed, so other risk factors of pancreatic, other than pancreatitis, is the history of cystic fibrosis. Obviously, if you have a childhood history of cystic fibrosis, that is a risk factor. Alcohol use, right? If you're drinking heavily or used to drink heavily in the past, though both of those things can affect pancreatic functions and can cause EPI. Other risk factor is smoking. Smoking is known to cause pancreatic fibrosis and cause insufficiency of the pancreas. So that is another risk factor, right? And typically the symptoms of exocrine pancreatic insufficiency, and how I differentiate it from diarrhea, is that typically it is that oily, fatty stool which floats on the toilet and you just can't flush, right? It is typically what we call a steatorrhea, or means inability to flush a fatty or oily stool. That is the typical example, right? Which means that, and that is what happens is because your fat is not being absorbed from your stool, and that's when I suspect EPI, especially if you have a history of any of these risk factors. Right. And just like bile acid diarrhea, it obviously makes sense that these symptoms happen after you eat, at the end of the meal or during the meal, depending on the severity of your exocrine pancreatic insufficiency, right? It will happen related to meals. So it's very similar to bile acid diarrhea in that sense. A diagnosis is typically measured by doing a stool testing of elastase in the stool, which is one of the enzymes pancreas makes, and treatment will be pancreatic enzyme supplementation. And again, similar to bile acid binder, you titrate it to the effect. You titrate it till your symptoms are better, because one dose, just like bile acid binder, one dose might not fit all. Like if you're eating, not everybody eats the same amount of food. So the dose which works for me might not be the dose which works for Alan, because Alan definitely eats much more than I do. Right, that is a possibility.
Now for a quick word from our sponsors with resources that might support you. As someone with IBS-C, I've struggled with symptoms related to food for the majority of my life, specifically FODMAPs. My personal triggers, beans, dairy products, garlic, and onion, would leave me feeling bloated and uncomfortable after meals, especially whenever I was eating out or traveling or living my life outside of my home, which meant I either had to just deal with the symptoms or eat bland, awful food and miss out on experiencing the social interactions and the joy of food. Finding FODZYME was a game changer for me. This is an enzyme blend that targets FODMAPs, specifically the GOS that's found in beans, fructan in the garlic, onion, wheat, and even different fruits and vegetables, as well as lactose in dairy products. I stash this in my wallet, my husband's wallet, every bag I own. I take it with me everywhere I go so that I can simply sprinkle it on my meals, eat with confidence, and feel my best after. If you want to try FODZYME for yourself, go to FODZYME.com and don't forget to use the code THEGUTSHOW, all one word, THEGUTSHOW, for 20% off your first order. Are you struggling with bloating, constipation, or diarrhea, and you're still waiting to see your doctor? Take control and get answers with Gemelli Biotech's at-home gut health tests. The Trio Smart Breath Test is the only at-home test that is validated to look for all three gases that are associated with microbial overgrowth: hydrogen, methane, and hydrogen sulfide. That means it can detect SIBO, EMO, and ISO in one simple test. It ships right to your door, no appointment needed. You take it and you send it back, then you get answers. If your IBS symptoms started after a stomach bug or food poisoning, it could be post-infectious IBS. The IBS-Smart blood test is a quick at-home test to help identify it. Fun fact, 1 in 9 people who get food poisoning will end up with post-infectious IBS, and most don't even know they have it. With both of Gemelli Biotech's tests, you'll get clinically backed results in about a week, and you can take them straight to your provider. No waiting, no referrals, just answers. Find out which tests are right for you at getgutanswers.com and use the code AaronJudge25, all one word, AaronJudge25, to save $25 on your order. You can also find all these details in your show notes. And now let's get back to the show.
I think how to assess food intolerance. I think we're completing the loop. We started with food intolerance versus food allergy, and we wanted to, because again, like food is such an integral part of these symptoms, we wanted to make sure we spent more time on it. And I think, right, I think Alan very beautifully clarified like how to differentiate an allergic symptom related to food from an intolerance symptom in terms of timing of onset of these symptoms, the nature of the symptoms, and how quickly, and the physiology is different, right? So I think that is important to realize. So let's say you are sure, okay, based on what Alan just described, I definitely don't have allergy to a food, but I am clearly intolerant of this food, right? So and I get this question all the time: how can we test for what food I'm sensitive to or intolerant to, right? So there are two parts of it, right? One, I think for if they are related to FODMAPs, or if you found that you're related sensitive to FODMAPs, which are these fermentable oligosaccharide, disaccharide, monosaccharide, and polyols, or basically fermentable short chain carbohydrates, which you can digest. The typical process of identifying which FODMAPs you're sensitive to is working with somebody who is trained GI dietitian. You eliminate all the FODMAPs, you feel better, then you go through these reintroduction protocols to kind of see which FODMAPs you are sensitive to. So for FODMAPs, unfortunately, that's not a blood test available or any stool test available or biopsy test that's available to kind of identify which FODMAPs you're sensitive to. You will end up doing this elimination and reintroduction protocols to kind of identify which ones you are sensitive to. The other disaccharidases like the sucrase and lactase, I mean, again, I think I don't even consider them, you are intolerant to them if you don't have the enzymes to digest them. Those are truly lack of enzymes, right? So in my mind, those you're relying on biopsies, but you might be sensitive to them because you don't have the enzymes to digest them, right? Because if you're lacking the enzyme, how are you going to digest them? And of course, they're going to give you symptoms. But then outside of these two concepts of FODMAPs and disaccharides, such as sucrose and lactose, there are other foods which you can be sensitive to or intolerant to, right? So it's, and one way of assessing it is looking at IgG food responses. So backtracking, how is IgG food response different from other immunological tests, right? And I want to make it crystal clear that when you're suspecting somebody has a food allergy, you don't look at IgG, you look at IgE, E for elephant, because all the allergic reactions are IgE mediated, where IgE binds to mast cells and degranulates them, and then you have anaphylaxis or something else, urticaria, right? But in comparison to IgE, these food intolerances in some cases are mediated by IgG. And IgG are synthesized by immune cells in our body, but are very common even in healthy controls, because remember, food has always been foreign to our body, right? So whenever somebody starts eating, the body is getting used to it. And one of the ways body gets used to it is by mounting these IgG responses, right? And eventually you just accept the food. But obviously in some patients, that process is dysregulated. And we recently have shown that, that if you identify IBS specific food items. So what happened in this study, which study on the right, is that the IgG responses were measured in healthy control and IBS, and we identified food items which kind of differentiates IgG responses in healthy controls from IBS patients, and identified like, oh, these are 18 foods which really are very specifically or uniquely have higher IgG responses in IBS patients compared to healthy controls, and set the cutoffs based on healthy control data, right? And we did this double-blind randomized control trial where, using this IBS specific IgG testing, we randomized patient into one of two arms. One was elimination diet, where if you tested positive for one of these 18 foods, which are IBS specific IgG, on this IBS specific IgG testing, you would eliminate that food, right? That's the elimination arm or the actual treatment arm. And in the control arm, you would eliminate the thing you will not eliminate the thing you tested positive for, but you would eliminate something similar from the same food group, right? Like I give the example, let's say you tested positive for strawberries, right? If you're going to treatment arm, you'll eliminate strawberries, easy. if you get randomized to the sham arm, you'd eliminate blueberries, which are similar to strawberries from the same food group, but not strawberries. And that kind of rigor is important in IBS trials because of a huge placebo response. And again, food trials are obviously difficult to control because of inherent limitations. People can do a lot of things with their food. So we had to control for that. And even with this rigor of control, when we tested the outcomes, it was very clear that patients who got treatment based on this IgG food responses, they did better in terms of their pain and bloating symptom improvement compared to those who got the sham arm. So this was kind of in this very rigorously designed study, we found that IgG food responses, but I do want to highlight, it's not, there are lots of IgG testing outside available, and I don't think all IgG food tests are same because they don't use the same cutoffs. The food items are like 200 or 500 items long, and so they can be very erroneous. And the assay we used was specifically developed for IBS patients, is commercially available, and if you use that assay and eliminate based on response of that, people still seem to have improvement in their IBS symptoms. So that maybe is one way of personalizing this elimination phase for our patients. Instead of doing this blanket like low FODMAP elimination, which I do feel your pain, and I know how hard it can be when we just, I and Ellen can sit on this side and easily just prescribe that and like, why don't you try this? And the reality is it's very hard.
Before we get into the Q&A, I would love for maybe both of you to talk on this last part, which I think is maybe a hard question to answer, but can food tolerance be improved for IBS patients over time? I get that question when we see it with FODMAPs, right? Where maybe your tolerance to FODMAPs can shift a little bit, but when IBS patients specifically, whether it be due to some of these secondary things that we talked about, FODMAPs, maybe some of these other foods that are potentially triggering symptoms, like, can that actually be improved?
I could start, Prashant, and you can fill in and give your opinion. I'd say yes. The short answer, I think, is yes. If we can find reasons why people have IBS symptoms, so Prashant was mentioning, maybe someone has bile acid diarrhea, and we treat that, or potentially they have EPI or small intestinal bacterial overgrowth and they're treated. I've found, at least in my experience, that in those patients who clinically are doing better from some of these overlap conditions, that oftentimes they can go back to eating some of these foods that were bothering them. That would be my take on this.
Yeah. And I would just add to say that even with FODMAPs, you can develop tolerance to them. That even with FODMAPs that you were sensitive to, over time, it's possible that you're not sensitive to them anymore. And actually, the studies which have looked at long-term FODMAP intake in patients who have responded to the elimination phase and looked at like, hey, how are you doing at 12 months, right? And these are the patients who continue to feel better after 12 months. They have shown that the amount of FODMAPs actually they are taking is very close to back to their baseline, right? So over time, despite going back in the amount of FODMAPs you're eating, you can feel better. There are physiological reasons through that, because we have shown through our animal data and others have shown that the elimination phase of low FODMAP can actually reset some of these physiological problems with IBS, such as defect in permeability, defect in visceral hypersensitivity, and it can normalize them for some patients. And maybe once these things are normalized, right, your barrier is no longer leaky, your gut is no longer that viscerally sensitive, then maybe over time you can reintroduce these FODMAPs and kind of develop tolerance to them. So it's resetting it in some way that we don't totally understand how.
Wonderful. So we have a lot of questions. So I want to get to those. The first one I can probably answer as the dietitian in the room, but is a low sucrose diet sustainable? I've heard it's very hard to follow. Those with like sucrose isomaltase deficiency, the tricky part is that there's the sucrose level of sucrose isomaltase deficiency. There's also the maltose side. If you're simply kind of on more of the sucrose side, so sucrose foods are more of the trigger, like it can be very sustainable. Like it's pretty easy to test out your sucrose tolerance and make modifications. Just like with FODMAPs, it's portion dependent.
The downside is a lot of times it is finding substitutions for sugar. And while sugar is not what we consider to be an essential nutrient in our diet, it's a very enjoyable nutrient in the diet, and it's very available. And so it can be tricky, and there's a lot of creativity involved in it. And it sometimes can be pricey because some of the alternatives are hard to find. And so it can get more nuanced than just being sustainable or not. But you can meet all your nutrition needs on a low sucrose diet. Maltose is going to be in starches. That becomes trickier. If you are very sensitive and you have to modify your starch intake, that is going to change diet quality a bit. And again, portions are very true here. So there's ways of incorporating carbohydrates and starches and even fiber intake, around these parameters, but it can get really tricky. And that's where possibly utilizing the enzyme, the sucrate, as an option may be appropriate. A lot of ways of looking at it. But as a dietitian, I would say this is typically pretty straightforward and it is typically sustainable. However, there are going to be some nuances depending on the full picture. And even if you have other like FODMAP intolerances or something else. So I don't know if you guys wanted to add to that. I know you're probably not utilizing the diet as much in your practice. But your questions. So someone said, and this is very interesting, I've never heard this before, but she said, I've heard that those who are able to digest lactose actually have a mutation to do so. So the ability to digest lactose may be due to a mutation. So that is to say that those of us who are lactose intolerant may actually be normal versus those who can digest lactose. Is that true? And do we know if lactose intolerance is genetic?
There clearly is genetics involved, but I think probably what's important, again, I think it is normal for individuals as we get older to lose that lactase activity. So it seems like the genetics involved in lactose intolerance is probably more complex than what we might have learned in genetics, where there's an autosomal recessive, or you can trace your family tree and say, okay, this is clearly where the mutation is coming from. I'd also just like to stress that this is actually normal for individuals to lose this lactase enzyme activity as we get older.
And then Dr. Prashant, you mentioned a bile acid binder, the cholecystyrene. Someone said, what bile acid binder has been shown to be the most effective? Is it cholecystyrene?
We don't know. There's never been a head-to-head trial of any of the bile acid binders with each other, but also there is very poor data on bile acid binder compared to placebo in this population to begin with, which is very surprising and I know sad, but I think that is the reality of it. Unfortunately, there is these drugs have been around for a long time, and as for reasons which are obvious, when the drug has been around for a long time, there is generally not a financial motivation from companies' standpoint to study them, and it becomes very hard.
Great. Yeah. And it's used sometimes in IBS with diarrhea, even outside of the presence of bile acid diarrhea, but that hasn't been studied necessarily for IBS specific diarrhea. Is that correct?
It has been, but again, the studies are very small. They have almost never been powered to assess adequacy either in bile acid diarrhea or in IBS diarrhea in general. And I think that's part of the problem, right? Like I think we never have had a very well-designed studies for this disease or bile acid binder in general in the realm of diarrhea.
Right.
Alan, would you agree?
Yeah, I might add that oftentimes the choice between these bile acid binders comes down to palatability and patient preference. So some of these bile acid binders, like cholestyramine, it's a powder, and there's a lot of patients who just find it very unpalatable. Whereas some of the other bile acid binders come as tablets. So there is definitely a little bit of counseling with patients and just trying to see what would be the easiest for people to take.
And sometimes it's insurance, obviously, right, which is part of the problem. And I would say I have also found sometimes patients don't respond to one bile acid binder, but they do respond to the other bile acid binder. So I'm not sure how much of it is because of the reasons Alan mentioned, because they have a hard time keeping it or drinking it, or how much of it is truly there is a difference in efficacy that I don't know, or inter-individual differences in how the body metabolizes different drugs. So you can try multiple bile acid binders if one fails.
Great. And we talked a lot about carbohydrates, but someone mentioned, what about bloating, gas, or symptoms related to the ingestion of proteins? Does that go back to lack of enzymes? Are there ways of diagnosing kind of protein intolerances, or where does that fit into this picture?
Yeah,
Yep.
I can start, meaning the proteins out the difference, right? I think between proteins and carbohydrates is that the initial part of digestion of carbohydrates is has to do with epithelium, meaning or the small or the lining of the small bowel. They have the enzymes to start breaking them down, like disaccharidases, right? In proteins, that role is predominantly left for the pancreas. Like the pancreas is what's digesting everything with trypsin and chymotrypsins. And so unless you have deficiencies of pancreas to make these enzymes, and generally pancreas is not selective. Once it doesn't have an ability to make one enzyme, it doesn't have ability to make any enzyme, right? So unless you have difficulty in pancreas, there is generally not a difficulty in digesting or breaking down proteins, causing your symptoms. That is not to say that protein is not the cause of the symptoms, but it could be in general sensitivity and other processes like immune mediated, which we just don't understand. Like, for example, gluten is a very good example, right? Like gluten is not being digested, but clearly people who are sensitive not just to wheat, but gluten itself. And that is because of multiple facets that comes with gluten itself.
I know we didn't hit on like alpha-Gal syndrome. I know that's kind of been coming to the forefront. Is that something that you guys ever work with? Like, do we have a reliable test for alpha-Gal?
I'm not aware of one. Are you, Prashant? I think it's more of a clinical diagnosis at this point.
It is, meaning there are testing, but again, I think there are testing available at specific centers, but not widely available. And I think we also don't see a lot of it because we are in Michigan. That's kind of the other part of the problem. So I don't think. In the right history, you could treat, but you could find you could also talk to your centers or gastroenterologist about trying to send the samples out to these centers for testing, if that's possible.
And you talked a little bit about the food sensitivity testing. We also referred to a lot of stool testing done in clinic. What about stool testing that is done at home? And someone mentioned specifically the Doctor's Data Microbiology stool test, but I know there's a lot of different stool tests on the market. Does that have a role in looking at some of these conditions? Like your opinions or thoughts on those?
I guess with the caveat that I'm not familiar with that specific stool test, but we oftentimes will see patients coming in with stool tests where they're testing the differences in the microbiome. And I think at this point, it's difficult to interpret those specific tests looking at microbiome differences. So for one, we still don't have a clear understanding of what a normal, quote unquote, microbiome actually consists of. And then we also know that the variability in the microbiome from day to day is actually quite large. So taking a snapshot of someone's microbiome at one point in time, the clinical significance of that is still largely unclear.
Perfect. It's a great way to answer that. I know that those are really complicated currently. And I know there was a question about, are IgG tests reliable then for food sensitivities? I think you said, not all are created equal. Like the research is still fairly new, correct?
Yeah. Meaning research is new. Again, I would emphasize the study we published was a phase 2 study and not a phase 3 study. So, meaning it needs to be validated in larger sample size, of course. And as Erin just mentioned, and I have mentioned before, is that not all IgG tests are equal. So the test I was referring to was specifically developed for IBS patients and is, sold by one company. And I think that test showed efficacy in this study, but same cannot be said about every IgG test that's out there. For the reasons which I just said, IgG response is normal in healthy controls. You don't know how the test has selected the food, how they have selected the cutoff, a lot of problems.
On that same line, someone did ask, you talked about the leakiness of the gut, the intestinal permeability, which we know is present in some IBS patients. Does having a leaky gut make IgG tests unreliable because of that leakiness in and of itself, or do they play a role short term, or do we not know?
The short answer is we don't know. But I would doubt it would make the test unreliable. It plays a factor in how food is presented or food antigens are presented to the immune cells, right? But I mean, I don't think it makes the test unreliable. It's probably part of the process of why the IgG responses in the IBS patients can be different than healthy controls.
And then looking at bile acid diarrhea a little bit more, and then SIBO, as well as just chronic diarrhea. Someone mentioned that their experience when they have SIBO or tested positive for SIBO, they have those same experiences of running to the bathroom right after eating. We can see sometimes the inability to flush stool in some of these cases. Does that mean that those who have SIBO or they're already present with diarrhea, so things are moving too quickly, is bile acid diarrhea always going to be present? Is bile not really the primary, like, do you treat the SIBO, then you come back and reassess the bile acid component of it? Or how do you evaluate that relationship between SIBO or chronic diarrhea and then the bile acid connection?
Yeah, meaning Alan, feel free to jump in, but what I would say, if somebody, like, I am suspecting that they have SIBO and they've tested positive for SIBO, I would generally treat them, see how they are doing at baseline, right? And if they are back to like, oh, things are doing great, right? Like I am back to feeling very much close to my baseline, then I would just stop there. But like if things are like, oh no, when things are a little bit better, but not a lot. Like I'm still pretty symptomatic. Oh, I'm not going to the bathroom 10 times a day, but I'm still going like 6 times a day. That's not a good way, right? And then I would still suspect that there might be there might be other causes on top of SIBO, like bile acid in these cases, right? So meaning I think you can have more than one issues at the same time, unfortunately. Most people don't, but it doesn't mean that nobody does, right?
Yeah, I would agree with that, Prashant. I think they can co-occur, but they don't necessarily have to occur together. As Prashant mentioned before, I think it really depends on your index of suspicion, patient's clinical status, like what their history is. Do they have risk factors for either condition? Oftentimes drives our testing and how we treat patients.
Wonderful. And Prashant, you mentioned that you've seen some research on the elimination phase of the low FODMAP diet, maybe resetting some things to then allow more tolerance to FODMAPs. Is there any data suggesting the opposite of FODMAPs, or also maybe other foods, of avoiding foods and that increasing intolerance? Like, is that shown in research at all?
Yeah, meaning I'm guessing you're asking that if you that the so there are two pieces, right? Like I think one is like if you eliminate, you can reset, and you develop tolerance in long term. But the second part is if you eliminate too long, that's one of the questions, right? Like if you eliminate too long, there is a definite worry that you may lose actually the sensitivity you had, because remember, body's like an engine. If you don't give it the fuel, you will eventually lose its ability to kind of just totally deal with food, right? Food is always foreign to you. So if you restrict something for way too long, meaning and multiple food groups, then you run into the risk that like, and next time you bring it back, the body's like, what is this? Like, I don't want to deal with this, right? And like, its sensitivity develops because of this hypersensitivity that develops or anxiety that develops from the nerves in response to food. So that definitely is another concern. So Aaron would probably agree with me, like, is that like long-term restriction of multiple food groups, which is blanket elimination, is probably not any of us is going to recommend.
Wonderful. And then I know we talked, I'll have to spare our last question. We have a lot of questions that and it's hard to get to all of them within the time, but you talked a lot about like diarrhea specifically as a side effect and kind of the mechanism of why diarrhea can happen in many of these cases. What about the people who are dealing with constipation? Is it that maybe some of these conditions or food malabsorption as the cause of the constipation is less common? Is it less studied and understood of where there is that connection? Is there a clear connection maybe to some other causes? Like, where does constipation fit into the mix?
I would start, and then Alan, again, feel free to jump in. Is like, for example, like the IgG study which I showed you. If you look at the subgroup from the paper, it actually the IgG-based responses and the diet based on IgG works much better for constipated patients and patients with mixed subtype, those who swing between constipation and diarrhea, compared to diarrhea patients. So like the patients who just have diarrhea, right? So that we didn't go into that study even thinking about like that this is what we're going to find, but this is what we found, that patients who were constipated and patients who swing between constipation and diarrhea, they seem to benefit the most from these IgG food elimination therapies. And I think that is unique in some ways, right? Because it is clearly a subtype which is benefiting from this food therapies, where we don't have that much data available for secondary causes, which we just talked about, right? So that's where food comes in, and the again, a lot of these things, as I said, doesn't apply, like EPI, bile acid diarrhea, typically don't apply for constipation patients. But there are other issues like pelvic floors dysfunction, which does apply to constipated patients. Patients who cannot coordinate their pelvic floor is a huge part of constipation and can mimic as IBS when they actually have pelvic floor dysfunction, and that can be diagnosed and treated with physical pelvic floor biofeedback physical therapy. Alan, do you anything else?
Yeah, I'd agree with what you said. I think, we've gone over a pretty broad range of topics today. And clearly, as Prashant is mentioning, there are certain conditions that diarrhea is a pretty almost essential component of the diagnosis, like bile acid diarrhea. I would say if someone isn't having diarrhea, it's very unlikely that they have that condition. But then we also have other conditions like bacterial overgrowth or, certainly IBS that, it doesn't necessarily have to be part of the equation. And the other thing that's important to know is that some of the diets that we have for IBS, like low FODMAP, for example, we know it doesn't necessarily change bowel function and form. It actually works better for symptoms like pain and bloating. So I think, yeah, it's hard to say with broad strokes, but I think depending on what each patient's diagnosis is, certainly we try to tailor their treatment based on that.
Wonderful. Well, thank you both for coming in. This was extremely insightful and helpful. Someone mentioned that you guys were great communicators, and I agree. I think this is a lot of really helpful information. For everyone in the room, I will have the slides for you so you can watch the replay and have the slides available to go through this information, because I know it is a lot. But thank you both again for giving your time and your expertise to our community.
Yes,
thanks, Aaron.
absolutely.
Thanks, everyone.
Thank you for having. Thank you.
Yeah, this is a great event.
Are you listening to today's episode with the main thought being, what are the steps that I can take to get rid of my symptoms right now? While I hope that the information that we share in every episode of The Gut Show leaves you feeling more empowered and more confident in your body, it's not always going to solve your problem or give you a clear direction for your specific symptoms and your needs. The Master Method membership is an online program for the person with chronic digestive symptoms and IBS who wants step-by-step guidance to understand their body, address the drivers of IBS, reduce symptoms, and build resilience in your gut long-term. This membership includes a step-by-step course and a dietitian-led community that teaches you how to holistically address each symptom and the IBS drivers, how to reduce symptoms more strategically and with confidence, and guidelines for better gut health long-term so that you're not only thinking about today, but you're also improving your outcomes in the future. It is time to ditch the symptoms and get your life back. The membership is your first step. You can learn more and enroll at IBSmastermethod.com and use the code GUTSHOW, GUTSHOW, GUTSHOW for $25 off your enrollment fee.